Hello, this is Chapter 10, Lecture Video Part 2. Chapter 10 is Family Risks and Resiliencies. So we're going to pick up where we left off and kind of talk a little bit about some modern treatment models with working with families. So researchers have found that family-involved treatment is associated with higher rates of treatment compliance and retention than is treatment without family involvement. So if we include the family, there's a better rate of compliance. The authors of your textbook say that family should be a standard of addiction prevention. There is something called network therapy, and network therapy involves family and peers in relapse prevention. So that is kind of like what our focus is, not just working with the addict, but working with their outside network as well, which is family. CRAFT is something that your textbook talks about, which is Community Reinforcement and Family Training Approach. This is Robert Myers, and it includes 12 one-hour sessions. The goal of CRAFT is to teach skills, self-care, and feedback when the addict is sober from the family. It is different than Al-Anon because you can influence the addict's use and whether they enter treatment versus focusing on your own issues and needs and not the addict's. So again, remembering the Al-Anon's 3 C's. You didn't cause it, you can't control it, and you can't cure it. The effectiveness of this CRAFT approach is actually not in your textbook, but I have a little bit of blurb from some outside resources that I wanted to give you in regards to it. So Sisson and Azrin of 1986 recruited 12 adult women with an alcoholic husband, brother, or father and randomly assigned them either to an early version of CRAFT or to a traditional intervention. The results indicated that CRAFT was considerably more successful in getting the persons with substance abuse into treatment and reducing their alcohol consumption in comparison to the Al-Anon group. Miller was another study in 1999 conducted a controlled comparison of CRAFT, the Johnson intervention, and Al-Anon facilitation that randomized 130 caregivers of problem drinkers to receive 12 hours of contact in one of 3 conditions. CRAFT and 12-step had better retention than the Johnson intervention, which is consistent with previous studies. Participants tended to drop out of the latter intervention in order to avoid the family confrontation with the drinker. CRAFT intervention also engaged substantially more drinkers into treatment, 64% versus 23% of Johnson and 13% of 12-step. So I just wanted to give you a little bit of outside information in regards to CRAFT. The authors say that there is room for both approaches. Al-Anon helps family detach emotionally, and CRAFT helps them be more helpful if they want to be helpful. Family group conferencing is also known as family group decision making. Started in the criminal justice program, or Child Protective Services program in New Zealand, and it's where you get all of your relatives together that you can, and kind of all make a decision together. In the United States, 1.7 million kids have a parent in prison, often due to drug issues, many of whom will resume drug use in return, although drug courts are cutting into the rate at which they are reincarcerated. These kids or families need treatment, they need help. And we are using kinship care in situations where the parents are the addicts and the kids need family. So stages of change in family treatment. I know we've talked a lot about stages of change in regards to the addict, but just kind of touching a brief moment on it in regards to family treatment. For families of alcoholics, the literature found studies describing 3 types of interventions: family without the alcoholic present, couples to improve communication and promote being sober, and work with the whole family itself. So the stages of treatment, which again, we've covered before, we start with pre-contemplation. It's different from traditional treatment where only the addict is assessed. It prepares the family to try to influence the person to get help. Because remember, in the pre-contemplation stage, the addict is, kind of like teeter-tottering and not really sure that they actually want the help. In this stage, with working with the family, you're working on reducing frustration, reducing depression, and talking about it and being aware of feelings in the family. It's short term, it's not deep work, and you might describe family roles in this level. You can work on goals and also help the family understand different approaches to working with them and working with the addicts. The contemplation stage for the family is when the family sees the addiction as serious and starts to get upset. Some emotions may arise from that. So it's important that the family addresses these emotions before it gets too bad. Or the family might waver between like they can't help it, they can help it, they're doing this to themselves, they're not even trying to get help, but they can't help themselves. This stage, they're focusing on strengths and capabilities. Solutions are coming from the family, and they might be working on grief work, especially for parents of adult children with addictions who don't seem likely to change, and they feel like they've lost their kid to addiction. Their kid is still alive, but they've lost them. The preparation stage is the I can't take it anymore stage. You're introducing the idea of treatment of the addict and involving the family, and you're teaching motivational interviewing to the family to use with the addict. The action stage is the whole family is in treatment, if possible. Denial is over, the addict's ready to go, they're ready to change, and you're preparing them for the addict's attempts at, splitting up the family as they start to recover. So you're building solidarity in the family itself. Some interventions. On box 10.2, there's a story on page 412 of Ted Kennedy and the interventions for working with families. Feedback, you want to give feedback to the addict from anyone in their life. So spouse, children, doctor, boss, priest, coworkers, friends, whoever. Those people want to give feedback to feedback to the addict to try to help them in their recovery. The interventions could be gradual, or they could be done as a surprise intervention. And that's a possibility as well. If completed, with these interventions, a lot will enter treatment if they intervene. Some risks, it increases resistance, and it might increase denial in the addict, and possibly suicide in some cases. Family members often resist it and see it as too confrontational, and people don't like conflict. A more gradual approach to working than maybe an intervention might be training the family in motivational interviewing. Collaborating with the family, and the addict could be invited to participate in that collaboration, but don't surprise them, let them be a part of it right from the beginning. Whether or not they choose to be there or not is another thing. And then lastly, maintenance stage. We're seeking big changes and new ways of interacting as a family. You're maintaining the change without the role of the therapist, and you're risk proofing, trying to prevent high risk situations, identifying stressors and triggers, and being aware for these things when they come up. Having that plan in place in case these things should arise. So when we work with families with co-occurring disorders too, let's add that into it. Teaching families about biological nature of addiction. You want to help them understand what the role of medication is for the addict, risk of different drug interactions, how families can help reinforce compliance with medications, and again, using motivational interviewing techniques. In situations of domestic violence, shelters must assess for substance use. It's very prevalent, as we have seen. Dangers of working with couples could increase the risk of battering each other. While substance abuse programs use an illness model, we got harm reduction, motivational interviewing can be taught to both sides. And be careful not to try to get a person to leave the relationship because that it would be better for them if they're being abused. But they need to be confident in their own decision because they can resist change if they feel forced into leaving their relationship. So using solution-focused strategies would be beneficial. Some cultural considerations when working with family. You want to always look for the strengths in every family situation. So I'm going to break it down by cultures and talk a little bit about the family role in those cultures. So let's start with Native American Indian families. So this cultural population stresses the role of cultural or historical trauma in the backgrounds of American Indians and the need for practitioners to address cultural pain caused by government policies promoting family breakup in the past by removing the young people from their families of origin. There's strong ties to family and community. Family and community-based approaches are definitely recommended with this population. Assess for the history of traumatic events, including abuse or PTSD, and provide trauma-informed services. Acknowledge the importance of family history. and extended family members is an appropriate way to involve family members. Explore women's beliefs regarding healing and knowledge of cultural practices. Understand and acknowledge the specific tribe's cultural values, beliefs, practices, and customs. So be aware of these things. Be aware of the history when working with the Native American family. Let's move on to African American families. Extended family members play key roles when working with African Americans. Reciprocity, the practice of exchanging assistance, is an essential part of extended family life. So, I help you, you help me, kind of thing. Use language to involve recovery in the context of family and community. Using collaboration of family, develop a picture of the family support system. Find ways to engage the father or the male roles in the family in decision making, because a lot of times it's based off of the female role. And draw on the family strengths when working with this type of family. The Latino family. This family has higher priority than the individual, so family is more important than individual. Enter the family system as a learner. Latinos are diverse. Use a personal style and not a formal one with them. For many, talking about substance use goes against their family norms. So a psychoeducational approach might invite more participation than one where direct talk is expected from them. Expect awareness of oppression and being willing to explore. Spiritual values may be important, enduring suffering, forgiveness, repentance, and if relevant to their spiritual perspectives. We have Asian American families. Be aware of gender roles. You may need to make the first appointment with the father. That might be something to be aware of. Value a sense of expertise of the helper. Develop trust and build a therapeutic alliance with the family. Honor the importance of family. Asian communities can be tight-knit, so emphasize confidentiality. Do not assume regular sessions. Their value may be more crisis-oriented. Share your treatment plan with the family, or they may feel slighted by it. Appalachian families may live close together with lots of contact with extended family. They mistrust outsiders. They're pretty self-sufficient families. Fatalistic, what will be, is their view on things. There is a mistrust of government and bureaucracy. Community-based services may work better than expecting them to come some distance to a treatment center. The women may be the health monitors in the family. Work with them according to their level of awareness and competence to be the change agents. Provide factual information and expect them to come to their own conclusions. And also, this is, another family that we want to take note of is working with homosexual families, gay families. This is important because, let me get started and then I'll explain why. Anticipate that the family may be a source of significant stress. Rejection is from 3 to 8 times higher than any other family. So that was the big thing that I wanted to stress is you're going to see a lot of rejection from families of those who are homosexual. So they may reject their person. When possible, work toward acceptance. For mature patients or clients, they define their own family. Friends may be a family for them. They may not, talk to mom, dad, brother, sister, whoever. Anticipate more fluid boundaries than straight couples. Gay females may seek more support from ex-partners. And coming out is their choice, of course. So letting them choose what they're coming out about or letting them choose whether or not they're talking to their families about these things. It's very important to take into consideration some of the things that we just discussed in regards to family. Because when you're working with families of addicts, you want to make sure that you are culturally sensitive to the family themselves so that you don't insult the family or make the situation worse. You want to be aware of this and, again, working where the family is. Very important when working with them. A little bit real fast here before we end this lecture video is talking about healing. So how can we help the family heal? We want to rename the family. Avoid alcoholic and avoid addict. We want to stay away from those terms. We talked about in previous lecture videos how labeling can be, extremely detrimental to a person. And this could be especially detrimental with teens. AA and NA use these terms, alcoholic and addict. So we want to try to avoid that when we're working with family. We want to reframe the family. What have you found that has come out of this experience? Focus on resilience. So now that your family has undergone this situation, what have you found from it? What came out of this? How can we work on improving this family structure again? Kind of also bouncing off of that is reclaiming what was lost. Is it worth being able to fix the situation, or is it better just for you guys to go your separate ways and to, be civil, but not necessarily be that strong family bond that maybe you once had? So 3 things in healing with families: rename, reframe, and reclaim. 3 R's. And that is it for chapter 10 in working with families. So thank you and stay tuned.